For decades, medical consensus on severe strokes and persistent vegetative states has rested on a single foundation. When neurons go dark, they are permanently destroyed. But a series of clinical anomalies are forcing a reevaluation of this consensus. In isolated cases, patients trapped in deep vegetative states or suffering severe post-stroke paralysis are experiencing rapid, unprecedented restorations of function. And the catalysts are not experimental gene therapies, but common off-label medications. The two primary drugs driving these anomalies are zolpidem, a standard prescription sedative, and adanercept, an anti-inflammatory drug used to treat arthritis. By design, these medications are engineered to induce sleep or relieve joint pain. Yet, when administered to specific trauma patients, the outcomes are paradoxical. The sleeping pill awakens coma patients, and the arthritis injection restores the use of paralyzed limbs in a matter of minutes. These rapid recoveries highlight a mechanical reality. Functional hardware integrity often persists beneath the trauma, as systemic noise jams a processor that remains operationally intact. If the cells are not dead, we have to look at the environment they operate in. The alternative hypothesis suggests that the neural architecture remains physically sound, but becomes trapped in a reversible, high-gain inflammatory state. This condition is known as signal saturation. The brain's environment becomes flooded with systemic electrical and inflammatory noise, overwhelming its functional signals. Every neural circuit has a maximum voltage capacity. When the internal noise floor rises to meet that ceiling, the system clips. The signal for speech or movement is still being transmitted, but it is buried under high-amplitude static. Interventions like zolpidem and etanercept do not rebuild tissue. They act as chemical gain controls, suppressing the internal noise and actively resolving this state of saturation. Viewing brain trauma through this lens changes the medical objective. The goal shifts from attempting to regenerate dead tissue to flushing the excess noise out of a dormant system. The mechanics of this noise reduction were first observed through the zolpidem paradox. Following a severe traumatic brain injury, Louis Vaughan existed in a persistent vegetated state for 3 years. 20 minutes after his mother administered a crushed zolpidem tablet, he opened his eyes and spoke. A similar event occurred with Diane Katz. After a 2-year coma-like state, a dose of the sedative allowed her to regain consciousness, recognize her daughter's face, and speak. In stroke patients like Jonathan Poole, zolpidem temporarily resolved his auditory agnosia, restoring his ability to understand language and process numbers. Dr. Ralph Klaus identified the biological mechanism behind these awakenings. Following severe trauma, specific neural receptors undergo an epigenetic change to protect the brain from further damage. These altered GABA-A ion channels become supersensitive, allowing an unregulated influx of chloride ions that forces the cell to shut down. Zolpidem binds to these mutated receptors, restoring standard function. This halts the excess ion flow and releases the neuron from its suppressed state. This SPECT scan compares cerebral perfusion before and after zolpidem. Dark regions in the initial scan indicate severely depressed function. Post-dose, the parietal region, previously operating at a fraction of its capacity, returns to bright metabolic activity. The cells were intact, simply suppressed. A drug engineered to induce sleep in healthy brains awakens injured brains by removing profound epigenetic suppression. A parallel mechanism is observed in stroke recovery through Dr. Edward Tobinick's use of etanercept, administered via a precise perispinal injection. Years after suffering a massive stroke that left her largely unable to speak or walk, a patient named Linda regained clear speech and mobility within minutes of receiving the injection. Another patient, Antoinette, experienced immediate physical relief from severe post-stroke muscle spasticity and a decade of chronic paralysis pain. These recoveries are explained by the pathology of the stunned brain, a state where brain cells survive the initial trauma but go into a prolonged hibernation. A stroke triggers a chronic inflammatory response, flooding the neural architecture with toxic levels of a signaling molecule called tumor necrosis factor, or TNF-alpha. The perispinal injection pathway utilizes the venous system near the spine, allowing etanercept to flow directly to the base of the brain in minutes, bypassing standard biological barriers. Once in the brain, etanercept functions as a highly targeted anti-inflammatory. It physically intercepts and neutralizes the excess TNF-alpha molecules before they can attach to the receptors in the synaptic cleft. This chemical neutralization correlates directly with 3D perfusion scans taken of Antoinette's brain, which show immediate, significant improvements in blood flow to areas that had been dormant for 12 years. By acting as a chemical heat sink, etanercept strips the toxic inflammatory noise out of the environment, allowing hibernating brain cells to instantly re-establish communication. To unify these two seemingly different pharmacological phenomena, we have to look at the brain through the lens of systems engineering, as outlined in Pavel Baniak's framework for neuro-recovery. Baniak defines the neurovascular unit as a CPU triad, consisting of 3 integrated hardware components: the microglia, which act as security logic, the astrocytes, which provide cooling, and the neurons, which form the physical data bus. In a damaged state, the microglia security component detects trauma and locks into an aggressive attack mode, creating a hysteresis latch. This high-gain polarization remains after the initial trauma passes, trapping the brain in its last fail state. The resulting signal saturation manifests physically as the sensory overload, logic jitter, and cognitive paralysis observed in patients. Their hardware cannot process reality without severe distortion. These treatments directly target this latch. Etanercept acts as a heat sink to draw off thermal noise, while zolpidem limits excessive electrical current. This mechanically lowers the systemic noise floor, breaking the latch and restoring normal maintenance logic. Regardless of the initial injury, the critical step in neuro-recovery is mechanically lowering systemic noise so the hardware can exit its defensive latch. This framework demands a reevaluation of neurological deficits. When a patient exhibits severe cognitive or motor loss, the system must be evaluated for state-based signal saturation rather than immediately assuming structural cell death. Both etanercept and zolpidem achieve results because they share an identical mechanical goal: lowering the systemic noise floor to unlatch the system. The optimized recovered state of the brain is defined as laminar flow, a condition where signals travel cleanly and efficiently across the neural network without inflammatory interference. The hardware transitions from a chaotic, saturated state that clips every incoming signal and resolves into smooth, unhindered processing. Medical science is moving beyond simply managing the outward symptoms of brain injury toward actively unlatching dormant neural networks. By treating the brain as an integrated processor capable of laminar flow, we unlock the ability to give patients their hardware back, ending years of unnecessary paralysis and dormancy.